Abhishek, please start welcome address. Abhishek, can you hear me?
Yes, Suvin. Yeah.
Yes, please go ahead.
Okay. Thank you, Suvin.
Yes.
Good afternoon, good evening, everyone. Thank you so much for taking your time out for this wonderful session we have organized today. The ASSOCHAM southern region, which comprises of the entire southern states of India, we have been actively doing initiatives like this, as well as reaching out on ground to support families and people who are at need at this point of time. So this was a very apt time where we felt that we should have some eminent doctors across India coming together and sharing their journey, both in terms of what could be the self-care, post-COVID care, vaccinations, and there's so much of stories and WhatsApp forwards happening at this point of time. We really wanted to kind of hear some um, you know expert advices on many things. What could be the situation lies ahead for all of us together, and how can we more stronger and helping each other. So on that premise, our co-chair for the webinar committee, Matty York, came up with this idea that why can't we do something like this, and how timely it is, right? Yesterday I got vaccinated. I was not sure whether I will turn up for this event because I personally heard that there would be a lot of after effect of your vaccination. Yes, there are mild, but I'm perfectly fine. I'm in front of you talking to all of you. So I have done my first jab yesterday. So we have very eminent doctors, personalities across India who are joining us. Obviously, I will let Matty to talk about them more. We also have Mrs. Sudha Murthy's who have recorded a video message for all of us. Wanted us to kind of on the vaccination drive. So I will let that video also kind of talk and give us a sense of how vaccination is important for us. And you can see that we have eminent doctors from Bangalore, Orissa, Bhubaneswar, Delhi, Kolkata and Mumbai, right? So pretty much covering the entire geographical boundaries of our country, right? And hear perspectives from different states, right? What's happening in the on ground in those states. So I think it's really becoming a pan-India kind of a event today, and we'll hear perspectives from all of us. I will not take much time more on it, and really want to thank the entire committee of ASSOCHAM who put this together, and of course the leader Matty, who was kind of not only kind of conceptualized it, got every one of us on the board to kind of make it happen. Also, my sincere gratitude to the entire secretariat, Suvin, Umaji, and everyone at ASSOCHAM to doing this. So without further ado, I will now hand this over to Matty to take it forward. Thank you, everyone.
Thank you, Abhishek. Good evening, everybody, and welcome to this discussion on COVID-19. We are happy to have this webinar today, which is World Environment Day, and the theme is Reimagine, Recreate, Restore. All of us are experiencing the effects of the coronavirus that has turned our world upside down. COVID-19 has dramatically changed the way we work, live, interact with friends and family.
Email ID now.
We have learned a lot about this virus from the internet, debates on television, and lots from the WhatsApp University, which has become actually our lifeline. And there are many doubts and questions still that we have on the virus, on the myths of the virus, the symptoms, the treatment, especially vaccination, and the many myths that surround vaccination. That is why ASSOCHAM's Southern Region for CSR and Sustainability felt that this webinar could help each one of us to know the coronavirus a little better. And who better than our hands-on distinguished panel of doctors, as Abhishek said, from Bangalore, Mumbai, Bhubaneswar, Kolkata, and New Delhi. So let me just introduce them to you. Dr. Swarup Hegde, consultant, physician, and critical care specialist for the last 14 months, has been chief consultant of SRV dedicated COVID hospital in Mumbai, which I'm told is one of the first hospitals dedicated to COVID. We have Dr. C.S. Rajan, senior consultant surgeon, Bangalore, who is a consultant to many hospitals in Bangalore and has been a dedicated teacher and guide for DNB in general surgery for over 30 years. Interestingly and good for us, he has recently recovered from COVID. And we are very happy, doctor, that you're here to share your insights on your COVID adventure. We have Dr. Kunal Sarkar, leading cardiac surgeon in India and past president of the Indian Association of Cardiothoracic Surgeons. He is senior vice chairman and chief cardiac surgeon of Medica Hospitals, Kolkata, and chairman of the Kolkata Heart Foundation. Dr. Sarkar has also some valuable insights to share. He is popular in the West Bengal media and is always in the forefront of campaigns for public awareness on this pandemic. Dr. D. Rautre is a senior experienced cancer surgeon. He is presently with the American Institute of Oncology, Sparsh Hospital, Bhubaneswar. Interestingly, Dr. Rautre, during his defense career of 30 years, he had the distinction of leading the first Indian medical mission to the war-torn Mazar-e-Sharif in Afghanistan, immediately after the Taliban was defeated there in December 2001. And in recognition of his meritorious service, he was awarded the Vashishta Seva Medal by the President of India in 2003. We have Dr. Matthew Varghese, consultant orthopedic surgeon at St. Stephen's Hospital in Delhi. Dr. Varghese is an expert on injury control, epidemiology of injuries, pre-hospital care, and emergency care of trauma patients. On his Facebook page, Bill Gates describes Dr. Varghese as my inspiration and my real-life hero for fighting and having dedicated his life to polio eradication in India. Dr. Matthew is also very vocal on his thoughts on the coronavirus. We have a special word of thanks to Mrs. Sudha Murthy, Chairperson, Infosys Foundation. She took the time off her busy schedule to send us a video message to encourage each one of us to get the vaccination. Our moderator this evening is Dr. Marianne de Nazareth. She's a full-time freelance journalist in Bangalore and writes on a variety of environmental, science, and gender issues, and is an adjunct faculty at St. Joseph's PG College of Media Studies, Mount Carmel's College for Women, Jyoti Nivas College for Women, and the St. Joseph's Boys School for the 11th Standard. I'd just like to ask all the participants who attended this webinar to please key in your questions and thoughts for the doctors in the chat box. These will be answered at the end of our discussion. Before I ask Dr. Nazareth to take over, I would just like to acknowledge Uma Nair, Regional Director, South, Abhishek Ranjan, Chair, Southern Region for CSR and Sustainability, the webinar and communications team of Prarthna, Pratik, Kaul, Prem Sagal and Shruti Kurana, and last but not the least, Subin Narayan and the team at ASSOCHAM for coordinating this webinar. Thank you all for joining us for this webinar, and now it's over to Marianne.
Hi, good evening, everyone. I've heard that are going to have 200 participants, which is wonderful. And good evening, doctors. It is my privilege to be able to grill you all this evening. So for me personally, it's been a terrifying time. I've lost a number of friends this past week to COVID. So that is why I have a personal interest in today's program. And for our guests, this is your chance to listen to our 4 panelists who are specialists in their respective fields to give us advice on self-care, both to avoid getting COVID and also how to manage it if you do. And of course, to dispel any myths you might harbor, especially the ones flying around on WhatsApp. Do we wear a mask? Do we not? Do we maintain social distancing? Keep on enjoying family parties, my book club, or get-togethers? Can we jog or exercise without a mask? How important is it for us to follow lockdown rules? We are also very lucky to have a panelist who has pulled himself through a COVID attack and who will share his experience. So let's just sit back and listen to our COVID frontline warriors to give us invaluable tips on the best way forward. In these unstable and uncertain times, it gives me great pleasure to welcome the 5 doctors. I request each of you to take 1 minute each and describe your run-in with COVID-19 being frontline warriors. Could we start with Dr. Rajan, please? Dr. Rajan.
Doctor, you're on mute.
Okay, right. Sorry. I beg your pardon on that. I was open, but I don't know how it got muted. Good evening, everybody. Thank you for the opportunity to be with you guys. I have had what was a life-threatening situation just over 3 weeks ago. Prior to that, I was all precaution. I was very careful during the first wave and took both my vaccination doses of Covishield on 27th of January and on 11th of March. But in spite of that, I dropped my guard a little bit. I went back into surgical work. I was operating, and I may have picked it up from somebody, though we were screening everybody there. And from about the 20th of April, I went down with COVID. Symptoms got proved RTR positive on the 25th of April and went through the whole works of the disease. As and when the time comes, I will describe what that disease and spell was. My recovery has been very good, except for weakness in the legs, which is giving me a little difficulty in moving around. But otherwise, I'm fine. Mentally, I'm very active, and I appreciate the help of everybody who got me through this disease. Thank you.
Doctor. Thank you. Dr. Rautre, please, could you give us your, your run-in with any patient?
Doctor, you're on mute.
Okay. Well, not so much a specific case as a general experience about cancer and COVID. When you see a patient of cancer who has a threat of COVID, it's like a choice between the devil and the deep sea. So we have seen in this last 1 year that there has been a reduction in our footfalls, and it has been actually confirmed with a reduction in the number of surgeries, reduction in the number of chemotherapies, and all cancer treatments to the tune of almost 20 to 50% of what it was in the year preceding the COVID endemic. So COVID has taken a toll of cancer, and we expect that the after effects are going to last for the subsequent years, even after we've controlled the COVID.
Thank you, Doctor. On to Dr. Matthew Varghese, please.
Good evening, everyone. Thank you for having me over. I came into this area purely accidentally because I thought lockdown is and a pandemic is a 1 in millennium event. Let me keep a journal. And I started writing my diary on every day, what I saw, what I heard, what I read. And I kept noting down every day. And as people that I knew started becoming positive, the disease came closer home. And I talked to them. Some of them were so petrified they're going to die. So I thought it my duty to talk to them morning and evening. Initially, they were doctors. And I spoke to them morning and evening. And when they became all right, they were so grateful for what I had done to them. Then I realized what emotional trauma they go through. Therefore, as soon as I learned somebody is unwell, I would call them up and I'll talk to them. And I'll talk to them precisely and I'll document everything that I'm talking to them about. What was your symptom today? How are you feeling today? What is it that you're having today? Every detail. And that became a pattern. I realized their disease is taking a distinct pattern of evolution over a period of time that starting at March, we only read about them in the newspapers, but it's only towards the May-June period that we started having 1 or 2 cases. And by July, August, September, we had a large number. And that gave me a real insight into what is happening. And at one time, I would be talking to 25 to 30 patients morning and evening. It would take me almost 3 hours talking to them, 3 hours. And I used to tell them, okay, if somebody calls me if I have corona, I would say, okay, I'll add you onto my Schindler's list of patients. And they would be on till they're recovered. And by August, I knew the pattern had evolved. And I made a hypothesis on what I talk about. All of you may have heard or seen about what I talk about these days. We can discuss it later. But that's what got me into this. By now, I have probably interacted with over 350 corona patients one-on-one, talking to them every day. And I have an insight into their symptoms, their mindset, what they are going through, and what agitation they have. That's my learning, and I was learning all along. Plus, I did a project for WHO on disabled, the impact of COVID on disabled, and that gave me another insight. And I kept reading, and together, I'm before you.
Thank you. Thank you, Doctor. Dr. Sarkar, please.
Hello, ma'am. Thank you for asking. I hope I'm audible. Right.
Yes. Very clear.
Well, I think like all of you, we've also have had our share of close encounters with this ghastly little mass of RNA. In Bengal, we've really, my hospital, Medica, has been one of the principal private hospitals which have sort of shouldered the burden of COVID. And not so much in the first time round, but during the second time round, I think, like the rest of us, the enormity of the problem really overtook us. And we had about 300 odd beds in our hospital. Then we opened subsidiary centers, field hospitals, all different kind. And other than the routine clinical experience, it was really very, revealing and learning to be associated with what I consider to be the largest ECMO. ECMO is the most advanced form of life support you can give in COVID. where you oxygenate the blood outside of the body. And we in this hospital run India's largest COVID ECMO center. Most hospitals would probably have run 4 or 5 at one time. As we speak, we have 22 patients on ECMO at this point of time. So it has extracted its share of pressure from us. A lot of our youngsters have given a lot of energy, taken a lot of risk. And in the respite or the sort of time vacuum I've had from surgical work in this point of time, I've managed to finish the book, a part of which is about COVID, which will be released shortly. It's called The Sickness of Health. And where perhaps more in dismay than in appreciation, we try to share some facts about what the country's experience has been with COVID. So yes, I've not been touched by the virus, fortunately, myself so far. But I think, we've been through the grill, we've been through the oven, and it's been not only tiring, but also a very humbling experience. Thank you.
Yes, must be really exhausting. And please, Dr. Hegde from Mumbai, could you speak to us, please? Are you on mute too?
Yeah, I'm audible.
Yes.
Thank you for having me on the show, and good evening to all the distinguished speakers. I'm Dr. Swaroop Hegde. I'm a consultant physician and a critical care specialist. I started my first case in March last year on 21st, and we have been the first dedicated COVID hospital in Bombay, and we have been in functioning now for totally 14 and a half months. And I guess during this period, I've had the opportunity to run a COVID OPD itself for the last 14 months, where I think we have crossed about 50,000 cases in OPD and about 2,000 plus cases in IPD. It's been a long, arduous journey, about 20, 22 hours a day of work, a lot of big bats coming in from all sides, everyone having their own opinion. There's a lot of internet information rolling around. But yeah, I think now we finally kind of getting a hang of the whole situation, and hopefully we are seeing a significant downslide in the number of cases right now, at least as far as Mumbai is concerned. Because unlike most of the other places, we have had 2 major COVID epidemics over here. Most of the other places had only a second wave. But in Mumbai city, from last year, March, we have been seeing waves after waves after waves after waves. And it has been an enormous problem because the population is significantly too high, financial reserves are a problem, and the ever-changing guidelines can also be an issue with regards to COVID. But yeah, all's well that gradually and hopefully should end well. I have not really had COVID in the last 1 year. I had a fleeting fever in October. Subsequently, I did come COVID PCR negative. I was working during the period because we were run out of doctors since most of them were admitted in our own hospital for COVID, and subsequently went on to get cured by spontaneously in 5 days. I ran an antibody test 2 months later, which came positive. So I guess I've been a bit lucky.
Yes, thank you, Doctor. So we move forward and kind of lighten up slightly where we could share with the guests today and talk about the myths which are floating around everywhere on WhatsApp, the internet, everywhere. So Dr. Rajan, there is this myth which says you will die after 2 years from taking the vaccine. Could you enlighten us?
I'm not sure where that myth came from. It's not yet 2 years, so it's very difficult to predict for tomorrow and what is going to happen 2 years later. I really honestly don't know. But remember, science and evolution of methods to extend life have been put into place on a slightly emergency footing because of the enormity of the problem that's going on. And it is the only way you can curtail numbers now and bring down the incidence of the disease as it goes around. That there are immediate side effects, I very strongly say no, there aren't any. My first dose went through without any symptom, and the second dose I had a mild fever for 1 day. but it does not give you protection. It gives you a certain strength, and you are still liable to pick up the infection either directly or from the variant forms, because we drop our guard. Our masking, social distancing, and other things tends to drop. It is now in the air, and you pick it up. Having picked it up, you don't die. The vaccine keeps you going and gives you that additional strength, which kicks in at a particular point and again gets you over. It happened to me in an ICU, so I felt that change, and I attributed it to the vaccine. I think somebody wants to say something. Sir, you can.
Yeah, just to pick up, I think that was a very interesting question. That 2-year comment came from Dr. Luc Montagnier. And Luc Montagnier is the recipient of the 1986 Nobel Prize for discovering the HIV virus. He's always been, a bit of an anti-vaxxer, bit of his points of view regarding vaccine, because he's a very ardent anti-virus man. He's been coming after antiviral drugs as opposed to the vaccine form of therapy. And it's a different story to tell. If you remember the early 80s, when there was a tug of war between Paris and New York about the HIV virus, it's a different kettle of Pandora's box totally. But he is as controversial as he is brilliant. He's been known for these remarks, and he's a loose cannon once in a while. So this was one of the blasts from him, So.
Yes.
And thanks to media, this kind of blast gets picked up and highlighted for the sheer fear factor that it crosses, and improves the ratings of their publicity and their papers and their movies. So I'm sorry, that was a senior gentleman, as rightly said, a very known virologist. But at 89, to predict something 2 years in the future, I'll take it with a huge bit of salt, please.
Yes. So let's just go forward with the next one. They're all very interesting. So Dr. Rathre, yours is the COVID-19 vaccine can affect women's fertility.
Doctor, you're on mute.
Wonder why it goes into mute on its own.
I don't know.
Okay. A categorical no to that. At the outset, one needs to state that, most of the statements that are emanating from this, about this vaccine are still on trial. The studies are ongoing, and a lot of them have been extrapolated from vaccine studies of yesteryears, like the Flu or some of those vaccines. However, there is no data and on the ongoing trials, nothing to suggest that the vaccine would in any way impact the fertility of the male or the female. So they're absolutely safe on that count.
Okay, thank you. Dr. Varghese, yours is, if I've already had COVID-19, I don't need a vaccine. Dr. Varghese.
Already had a vaccine. I don't need a vaccine. Vaccine against corona, or
I've already had COVID-19. I've had the illness. Do I need the vaccine? That's it.
if it's COVID-19 illness, then I don't need a vaccine. If you look at the number of cases that have come who've had the disease after having the disease once, you would notice that we've had, like in my list of Schindler's list, I've had about 3 of them coming to me very clearly saying, and they had told me earlier when they became positive, that they had the disease once. So 5 months down the line, 6 months down the line, they got the disease all over again. So we have no idea how long does the immunity from this disease last. We have no idea. Normally, we would expect it to last for about at least 1 year or so. That's what we do in a flu virus. You take it annually before that season. But here, we are seeing cases where you've had the disease once, and in about 5 to 6 months, you have the disease, including RT-PCR positive within 5 to 6 months. Therefore, we are unsure about the degree of protection provided by the disease. Hence, it is wise to have the vaccination because we want to protect as many as possible. And therefore, and the risk of vaccine are lower than the risk of having the disease. So in medicine, we look at the risk versus benefit. So we want to see if you've had the disease, are there any risks in having the vaccination? In whatever has been done so far, as Dr. Rautre said, the results are still evolving. The history of the vaccine is very short, and therefore it's too early for us to be categorical about anything. We are learning, and as the disease evolves, as the vaccine rollout continues, we will have greater clarity on the adverse event following the immunization. So until we have data compiled, analyzed, and sufficient time is given, for the moment, the risk of having the disease is far greater, and therefore it is worth having the vaccination even after I have COVID. Only there is a caveat there. We do not want you to start the immunization within 3 weeks after having the illness. That is a science, because your early immunoglobulins will destroy the vaccine which is trying to generate the antibodies, because these early antibodies will destroy the vaccine itself. Therefore, you definitely wait for 3 weeks at least. But the regulation is if you had the disease, then you have to wait for 3 months at least. So that's a regulation. The science is not before 3 weeks, but the regulation is after 3 months.
Thank you, Doctor. And onwards to Dr. Sarkar, researchers rushed the development of COVID-19 vaccine. So its effectiveness and safety cannot be trusted. Could you comment on
it? You see, I think overall, it is absolutely true that if you think that for how long was smallpox with us before we get on to vaccinating it? Smallpox was with us for about 10,000 years. You know, before the gentleman called Edward Jenner put in 2 drops of vaccine in 1796. And similarly, you know, when polio vaccine came on with Jonas Salk, you know, somewhere in the mid-50s, early 60s. So it's taken a jolly long time for every vaccine to get developed. And it's again a different twist to the tale. But in the last 2 weeks or so, we've had quite revealing stories about how the COVID virus actually erupted. And the kind of storyline at this point of time about the lab outbreak is rather strong. You know, the whispers are rather strong and gaining strength by the day. Now, the question remains that, you see, the time taken for, if you consider Bharat Biotech had a brilliant vaccine against rotavirus, and that took about 5 years to get into clinical use. Now, why did it take 5 years? The scientists did not take 5 years to formulate it, but the reason it took 5 years because your regulatory processes were very long. Yeah, phase 1, phase 2, phase 3 for very long. So we've like zipped it, we've kind of compressed it. But again, when times are desperate, you do cut corners. Sputnik has arrived in India. Sputnik is being put into people, but Sputnik has still not presented its complete data set of stage 3. It's come out with a brief report in the Lancet. That's it. Similarly, we cannot be too nationalistic. On the similar is the status with Covaxin. So with the exception of Covishield, when Jenner Institute came out with their exhaustive reports, and to some extent the mRNA fellows, most of the other vaccines floating around in the market are not differentiating between a report and the actual scientific data set. So I think people, by and large, both curious people, science writers, journalists, and doctors would feel a lot more sort of confident if the actual robust data sets came out, right? So I think that is where the companies are also being a little bit laconic at this point of time. So, but I think by and large, as we heard from our other speakers, that if you consider, I think about nearly 1 billion people have been vaccinated in the world. And if you consider that the incidence of side effects. There is nothing in the world, without a side effect. There are some people who even died after an haircut. So everything has its side effect in the world. So
That's true.
some people collapse having got married. So in that way, India's mortality from road traffic accident is 3 times its mortality from COVID. So that doesn't mean the roads are not we have not called Indian driving conditions pandemic so far.
Yes,
But
that's
so
true.
be it.
Thank you.
But so far they've acquitted themselves fairly well.
Thank you, Doctor. And on to Dr. Hegde. Getting the COVID-19 vaccine means I can stop wearing my mask and taking the any coronavirus precautions. What do you have to say on that?
First, let's make it very clear that taking the vaccine in COVID-19 does not mean that you're not going to get COVID-19. What it does is it basically tempers down the infection, offers your body starts to have its own immunity complex, which it did not have prior to the vaccine, or unless, of course, you have had COVID already once. In such a circumstances, the vaccine by itself will only help build up an immunity, which helps fight back the infection. And from our clinical observations of the HRCT of those patients who have had both vaccines and thereafter developed COVID-19, we have realized that usually most of these patients have not really had a severity score beyond 5. In normal COVID infections, you may have up to 100% COVID infection, which means that you could have a 25 on 25 score, depending on how the scorings are done. Whereas in those who are vaccinated, we have realized that they usually are not crossing over the 5, which indicates that in most cases, people can asymptomatically get away without treatment or with a minimal over-the-counter medication or some sort of a temporary residual admission. These cases can be managed. But please note that even after taking the vaccine, you can get COVID-19, you can get a pneumonia, you may require hospitalization depending on your age and comorbidity factor. So yes, it is unlike what was told in the US that because you're vaccinated, you need not wear the mask. That's completely untrue. You still have to follow all precautions till as long as the entire population is vaccinated, because a certain irresponsibility from those who are vaccinated can put at risk those who are not vaccinated around them. So all COVID protocol measures have to still be in place at least till the end of this year, till we are definitely sure that we have kind of achieved a total vaccination. So yeah, you do have to, as of right now, that mask has to be still on and it has to be worn properly.
Thank you, Doctor. So now let's just move on to more serious issues, because these are the myths which go around and people just believe whatever's being told. I'd be really grateful if each of you could keep your answers sort of brief so that we can pack in a lot more. My first question is directed to Dr. Sarkar. Why is COVID-19 such a dangerous threat to the human race, unlike other coronaviruses which cause the common cold that affect us during the year, but are not life-threatening for otherwise healthy people? Why is it such a threat? Maybe you're on mute. Sarkar?
Oh, sorry, ma'am, I was on the phone. Would you just repeat your question for a minute? Yes.
I said, why is COVID-19 such a dangerous threat to the human race, unlike the other viruses which cause common colds and affect us during the year and are not life-threatening? What is different here?
I think, what's really different with COVID-19 is 2 things. One is that it was so utterly unrecognizable to our immune system. Now, again, we are in the realms of controversy that whether it was really caused by an infringement, like a species jump from the bat to the pangolin and pangolin to human being. The only problem with it is in China, you see where the bats were found and where COVID was found, it was separated by a distance of 1,500 kilometers. Bats can fly, but I'm not sure they can fly that far. So there are a lot of big holes being drilled at the moment into the natural field hypothesis, and it appears likely, I wouldn't put my money on it as of this afternoon, that in Wuhan, you see why it is so lethal is because in Wuhan, there were specific people. The whole brief of the Wuhan Institute of Virology was to work on a coronavirus and to sharpen its fangs and claws like the spike protein to make it more sort of penetrable as far as the human cell was concerned. A gentleman called Nicholas Wade has written very extensively in it on the Journal for Atomic Scientists, and you're all welcome. Science Wire has sort of done a simpler version of that story. It's very exhaustive, very scientific, very detailed, and you're welcome to read through it. So I think, it was almost like custom made for infectivity. Either did nature design the custom made or did we do it in a lab is a little point of controversy. This kind of research is actually called gain of function research. So you are trying to predict years ahead what nature would do. So all in all, this thing was sharp. This thing was utterly unfamiliar to the human immune system. And anything that spreads through the respiratory tract is extremely lethal. So everything combined, and the last point where it has really beguiled our physicians, our ability of conventional medicine is, it is not the virus which by its sheer presence that causes the harm. We kind of auto-destruct ourselves because of our bizarre immune response to it. Those 5% people who suffer badly, you see, one myth has to be broken, which is you read out all the data and you say that the mortality from COVID has been 1.8 or 2%. You see, that is the case fatality. If you look at hospital fatality, it's much higher because if 10% people get into hospitals and the total mortality is 2%, then it implies that the hospital mortality is 20%, not 2%. Right.
That's right.
So all in all put together, I think these are the factors because we are suffering because it is such an alien business to our immune system that the damage is not from the, unlike bacterial infections, the damage is not from the mere presence of the virus, but the way it has triggered our immune systems as a Mad Hatter kind of response. And that is where the therapeutic confusion still lies. And we are unable to predict that which of the people would behave in an insane manner and which of the people would have a sane response to the immune system. We honestly, to get back to the bat, we are still as blind as a bat as far as that is concerned. So these are the factors which are making it very lethal at this point of time.
Thank you, Doctor. Thank you. Dr. Rajan, if you could just briefly explain to us, from a patient's point of view, what was it like to pull yourself through? Did you feel that you were not going to do it at any point in time?
Oh, yes. As I had said, from the 20th of April, I got symptoms. I took it lightly. I followed all precautions. I isolated myself, got positive on the test on 25th of April, continued isolation, but my fever and overall weakness never left me. And it was quite sudden on Sunday, the 2nd of May, I began to get this shortness of breath. And it was getting worse. And so on the 3rd of May, I managed to find a bed in my old hospital where I had spent my career, that was St. Martha's, Bangalore, kind enough to have accommodated me into a general ward. And when I got in and I had the preliminary tests and other things, my CT score was 9 out of 25. Again, people said, this is mild, you will come through. But on the night of the 5th, I got extreme amount of goosebumps. Everything was all standing up. And my pressures began to fall, blood pressure, and my saturations dropped right down to the 70s. And then they all said, this gentleman is in problem, and they shifted me into the ICU. And I was there with a mask and up to 15 liters of oxygen. And around me were ventilated patients. And on one night, 4 of my neighbors passed away. Now,
my
that's a
gosh.
huge shock to you. You see,
Yeah.
listen, there he's there and he's gone. And all of them younger than me. I
Okay.
probably had a problem because I had a comorbid. I'm a post CABG person. I've had my bypass done. My heart started behaving a little irregular, and I went into bradycardia and not enough heartbeat. So there was some general systemic effect that pushed me to being so acute. However, on the third day, the change was very remarkable. I suddenly found an easing of symptoms and I was able to breathe easily. And I quickly came out of that ICU. I needed oxygen for about another 5 days to support me. And I was home on the 11th day. But those 3 days in the ICU were psychologically very traumatic. And the whole shadows, black shadows of life closing around you, and you're wondering, am I going to make it? Am I going to come out here, or am I ending up in a coffin 6 feet deep? And all the memories of the past, all the memories of the loved ones kept flashing past. No sleep. You just cannot sleep. Your mind is so agitated. And
Thank
then
you.
you come out of it. So it is a very, very traumatic experience. One I'd never wish even my best of friends, worst of enemies to have. And I think it's that final bit that the vaccine kicked in and caught me. If I didn't have it, I was probably a goner. So I really feel the psychological trauma of a person who comes out of ICU is something that nobody can describe. And it is a very disturbing feeling, very, very disturbing feeling.
Thank you. Thank you for that sharing. Dr. Swaroop, you manage a dedicated COVID hospital for the last 14 months, one of the first in India, and the virus is mutating. So how are you as a doctor managing with the newer variants like the Kappa and the Delta?
See, with regards to any of these viruses, I mean, for that matter of fact, any coronavirus or any virus, you're going to have a lot of minor mutational changes that will happen over a period of time. That is the nature of the virus. In spite of the fact that you do have now about 8 or 9 different mutational variations, like you have the Kappa, you have the Delta, you have a Theta. Almost every country seems to have its own one strain which is there. Whether it's the Alpha is the UK and South Africa is the Beta. So, I mean, these are minor mutational changes. We're talking about 1 or 2 mutational changes that can either make probably the virus a little bit more infective and probably make it a little bit more virulent. But the primary modality of treatment still does not change. I mean, it continues to remain the same. So as of right now, even though there are multiple mutational strains around, now we don't have a proper mechanism in India where we can, we can verify the different strains that are running around, because, I mean, we need to get the NIV on the same page when we get this, the National Institute of Virology, just like the CDC does in the US. So for us to know exactly what are the strains, predominant strains running around. But for the matter of fact, if you ask us as COVID doctors, for us, it doesn't really matter what strain the patient is carrying because we do not know what they have. We treat them based on whatever symptoms that they have. If they're symptomatic, we treat them for the symptoms. And I think the rest does not matter because the protocol of treatment would be the same. The rules and regulations, even for preventive, are still identical, whether it is whatever strain that you're seeing. So these strains and the so-called different names that they're being given, they're of less importance, obviously, unless, of course, that over a period of time, you start getting more and more virulent strains. There's one about the Vishakhapatnam one. So there are different ones floating around. Now, only once we get to see what the presentation of each of the strain is in its totality, could it make a difference in the line of treatment? Otherwise, for us, I don't think anything changes, irrespective of whatever the mutational strain that is running around.
Okay, thank you. Thank you for that. And Dr. Varghese, how does the virus infect us? I mean, how does it, we've been told you sneeze and cough into your elbows, maintain your 6 feet. When the man brings your vegetables to the door, spray the packets, that was what it was earlier, wash the vegetables. But it's not the same today. The man comes, he gives you your stuff, and you're not doing all that washing that you did last year. It's really a bit confusing. So could you explain what we should be doing?
Yeah, actually, there has been the scientific world and the medical fraternity also have added to the confusion, because earlier all these guidelines came, it is spreading, not by aerosol. It is not aerosol. So that statement came up again and again. It's not aerosol, whereas many of us felt it was aerosol.
Yeah.
Then the statement was revised. Then they said it is all fomites. So it is your vegetable, it's your newspaper, it is your,
Yes.
the person who's bringing your, home delivery stuff and whatever. So there are all kinds of stories floating around. Pizza delivered person at home, and the pizza box carried the thing back home. So all kinds of WhatsApps, university and other social media stories were floating around. But the fact remains, and then of course the regulatory authorities also added to the confusion. Initially they said it is only these 6 feet. Then they changed it to beyond 6 feet also. So we've added to the confusion by not having a scientific data coming from one reliable source or one or two reliable sources and then disseminating it widely. The fault is ours. Having said that, the bottom line today is the fomites, means transmission by your hands touching an object being contaminated is not a major source of contamination.
Okay.
It is not a major source of contamination. So you don't have to worry from fomites as much as we were worried in the early phase of the disease. Having
Yes.
said that, this
Yes.
strain is clearly different from the earlier strain. So the Delta strain is clearly far more contagious than the other strains that were there, because it is very clear. So when we had in the previous wave, or previous waves, as Dr. Hegde puts it, we have had many waves. In the previous waves, you would see one person or two persons in a family being positive. This wave, when I spoke to the patient, and I was adding 5 persons in the list, 5, everyone in the family, including the housemaid and the driver. They were all positive. So anybody who was breathing in the same airspace for even a short span of time got positive. So it is the contagiousness of this particular strain which determined the spread, and most of it has been the aerosol variety. But if you really have interaction with the patient, maybe taken hands with the person, you don't get it straight on. But research has shown, and this is earlier research, this is not COVID really, post-COVID research, no. Early research, the behavioral scientists have analyzed how often do we touch our face. They found that
Yes.
a normal human being in a normal situation without mask touches his face at least 20 times to an hour. 20 times to an hour. So we have to be careful. I always say this. I always say this. We feel very protected when we're having this mask. Now,
Yes.
the filter is on the outer side. If you've been to an area where there are aerosols with the virus in it, the virus gets filtered here, and we breathe in the clear air free of the viruses. Then what do? You take it off like this, touching here, and then take it away, and then you do this.
That's right. Yeah.
That it spreads through your mucosa, not through your skin, through your mucosa. So this is dangerous. So I keep time and again, I keep explaining. I demonstrate it also in wherever I get an opportunity in webinars. Please, touch this part of the mask. Take it off from here. Take it off from here, and don't touch it. And don't touch it there and hang it away. And if at all, even after this, my thing is very clear. I use the sanitizer very nicely, not just here, a little small bottle, put a little bit here and that's it. No, all around, this, all around. That has to be, in fact, soap and water is far better. We are having allergies and all kinds of things with this solution. And many times the alcohol content is lesser than what it should be. If the alcohol content is less, and alcohol also, especially if you keep it in the car, alcohol evaporates away. What is left is a gel and some water and some of those aloe vera and other things which you very happily procured. It is useless. Soap is far better. It's far better to use that. So the bottom line is the spread is clearly aerosol. Be with a person and having your mask interaction face to face. And biggest mistake again, one person went to a wedding. He asked me, can I go? I said, provided you don't take your mask off. Oh, I said, in dinners, we take off our mask. we have tea, we have soups, we take our mask off. Same way in the aeroplanes. I have seen everybody has a face shield also. But when dinner time comes, everybody has a mask down, face shield down, everything is down. And you're breathing in the air which is there in the closed space. So it is the aerosol which is most common, but this is also there provided you're not careful. So your care, as Dr. Hegde mentioned, remains whether you're vaccinated, unvaccinated, whether you've had the disease or not had the disease. You have to be careful all the time till this pandemic is done away with.
Yes. Thank you, Doctor. We really raced forward. We're kind of running out of time. Dr. Rautre, I'd like to ask you this question. It's a personal one. I'm a regular jogger. Is it safe to go for a morning jog on the road without your mask? Or because I go without a mask at 6:30 in the morning. Is it possible that I could get the virus while running on the road and, bring it back and infect my whole family? What about the lift where, we touch buttons, a whole lot of vendors and residents come into the building? Could you give us a little more clarity on that? How safe is it to be jogging without a mask?
Well, see, the first thing is that initially there were a lot of studies done about the use of mask during any kind of exercise. And they did data did show that the oxygenation was less when you were wearing a mask, and therefore your physical endurance was compromised. That's point number one. Point number two is when you are in open spaces for whatever purpose, your the threat of the virus and your risk thereof is much less as against a gym or a lift or any closed space.
Yes.
If you put these 2 points together, I would personally prefer to keep my mask down, keep it on, but keep it down when I'm jogging in the open. And to ensure the aforementioned things that, I don't come close to any people. I'm on my solo mode. I'm not doing a group jogging. And whenever I see any person, I move a little away so that I'm, at least 6 to 7 feet away from that person. And it ensures that my endurance is optimal.
Yes.
But in lifts, etc., in closed spaces, I would definitely go with a mask. Yeah, done.
Yes. Yes, thank you. Thank you for that. So, Matty, would you like to go ahead now and put on the video?
As I said, we have a special video from Mrs. Sudha Murthy. Suvin?
Yeah, sharing it now.
Yeah, thank you. Suvin, there's no audio.
Yeah.
Suvin,
Yes.
there's no audio.
Okay, actually it was working. Just is it audible now?
Yes.
Yeah, it's audible now, just a little louder it needs to be.
Yeah.
Thank you.
Only with that help, we can fight corona away. Please don't get scared. I myself have been vaccinated. 2 portions, and nothing has happened to me. You may get fever or may not even get fever for a day. Don't get scared. Don't listen to people who tell you false information. Don't lend your ears for false propagation. This is the best way. ASSOCHAM is a good foundation which will help you to make all these awareness camps for all of you. Please listen to them, get vaccinated, be healthy, please stay away from each other, please stay at home and look after your health. Vaccination is the best weapon, do not neglect it. Thank you very much for patient hearing. I am Sudha Murthy from Infosys Foundation.
Thank you. So we can go on with further questions. Moving on to the symptoms. What does the common man look for with symptoms? So Dr. Varghese, what exactly does the word asymptomatic connote? Is there any way of knowing if anyone is asymptomatic, or how long does it take for symptoms to show? Can you, explain that a little bit?
Is it me?
Yeah, Dr. Varghese.
Okay. Yeah. See, the problem is 80% of people that have the disease have very mild symptoms. Very mild symptoms. They're like any common cold. They have a little sniffle, little sore throat, little body ache, mild feverishness, not even fever recorded. They feel feverish, they don't record the temperature. And that's it. They have nothing else. The earliest studies, when the pandemic had just been declared, there were two categories of captive patients or captive people. And the classic one was the Theodore Roosevelt aircraft carrier in the US. This aircraft carrier had US Marines in them. And they found that when they tested them for the RT-PCR, for the antigens, they found that 60% of them were positive. 60%, whereas they had zero symptoms. Zero symptoms. They did not even have a sniffle or a cold. So this was one of the earliest cases which gave a warning to the physicians and the epidemiologists that this virus behaves in a bizarre pattern, creating no symptoms in one group and creating a lethal symptom and death in the other group. So this spectrum is so wide and the outcome is so bad that you suddenly, though you're asymptomatic, even the slightest symptom gets you on anxiety level that is way beyond. In fact, in some of the surveys that we did among the caregivers and the disabled, the number one complaint of these people, sleeplessness. They couldn't sleep at night. So the anxiety level goes up even if you have the slightest symptom. So the symptoms were very mild, exactly like that of a common cold. That's it, but much less severe than a common cold. Common cold, you're sneezing, you're running, your nose is running, you're dripping. None of those things happen. There is a blocked nose, but there's no running nose. There's a little headache, but not too bad. You don't feel that incapacitated as. So therefore, there is a tendency to ignore it. And there are patients who have a little cough. When I talk to them, no, I've had a cough for 6 months.
Okay.
Oh, I've had a cough for 6 months. Now, obviously, that cough is different from this cough. They're equating the two. Or I did this extra cleaning in the house and therefore I have body ache. So human beings tend to rationalize because they are in their denial mode. They don't want to accept that maybe it is corona. They want to deny it. And therefore, they ignore minor symptoms. They deny minor symptoms. That's one category. But there's another category which is truly asymptomatic. So the disease, as was mentioned by Dr. Sarkar, it is creating a full spectrum of conditions. So we need to be aware and alert. So our index of suspicion has to be high so that we don't miss that person who is symptomatic very mildly in the beginning and soon gets up to be wanting breath on a ventilator.
Oh, okay. All right. And Dr. Rauta, you deal with patients with cancer. Is it a challenge to diagnose coronavirus in lung cancer patients who have the symptoms? Are the symptoms all the same with the cough and the breath, inflammation of the lungs? Dr. Rautre.
Can you just give me the question again? There was a little distortion. I couldn't.
Okay, so you deal with patients with cancer. Is it a challenge to diagnose this virus in lung cancer? And many of the symptoms are the same, like a cough or shortness of breath. What are your thoughts on that?
Okay. So we have what you're telling me is that we have a patient, a known case of lung cancer.
Yes.
He now develops fever. And now we presume that he's a survivor of lung cancer who's completed his treatment. And he is without evidence of disease insofar as his cancer is concerned. And he now, in the subsequent follow-ups, develops fever. He will be attended to on merits of the disease. The fever will be addressed as per the standard protocol of giving him antipyretics, keeping in mind that he could be having the COVID. He will be tested for COVID. The only point of concern will be that when we get an HRCT done for him, that's a chest CT, it would be well advised to give the radiologist the last CT film that this patient had when he was being treated for lung cancer, so that the radiologist has a basis for comparison and can opine of any change or none thereof. Another point to note is that when we say that a cancer patient is at increased risk for COVID, one of the cancers which is at increased risk is a lung cancer, because you have a compromised lung, and we do know that COVID hits the lung the hardest. Most of the fatalities are because of the lung injury. So it's a double whammy for this patient with an already compromised or a diseased lung and now being afflicted with COVID. So these patients need to be tended a little more vigilantly. So if a lung cancer patient has fever, I would even disregard the standard guidelines and immediately do a HRCT.
Okay, thank you. And Dr. Sarkar, you are dealing with, cardiac problems and patients with comorbidities and issues, cardiac problems. Have they to be more watchful about symptoms, like a fever and a cough and fatigue and shortness of breath?
Ma'am, they would be. You see, one thing that has been noticed during the second wave is that we've seen by wave, we've actually seen far less cardiac problems as we saw in the second wave. Because in the first wave, we saw people who were relatively, say, in their 50s and 60s, they were coming with irregular heartbeats. There were a couple of times when doctors were almost tricked into thinking that something was a heart attack, but they found out that the nasty-looking ECG was not really due to a heart attack, but an effect of COVID, etc. But in the second time round, you see what's changed by way of presentation or symptoms is as if the virus is in a great hurry. Whether you call it Delta, etc., 1617.2, whoever it is, it has completely been heaving destructions on a faster mode. It's like working times 2, because previously we were going through the complicated form of the problem in the second week. This time it's all happening from day 3, day 4 onwards. And maybe there are cardiac effects in the seriously sick. Maybe we are really not getting time to have a look at it. But consider those people who've been in hospital. Because look, any condition that has an in-hospital mortality of in the range of 15 to 20% cannot be trivialized.
Yes.
There are not many diseases. Even if you've got run over by a bus in this day and age, you would really not end up with a mortality rate of 15 to 20%. So it is not to be trivialized. Maybe because people who are ending up in ICUs and high flow oxygen, etc., getting onto ventilators and ECMO and all that, maybe we are not picking them up. We are not getting time to pick them up because the bullets and bombs are flying all around us. So I think that is an observation this time round. And it has been far more ferocious in the sicker cohort than the last time. So that is something we see. And you see, we've seen, people of our generation and those senior to us, we have seen, pneumonias dime a dozen.
Yes.
This pneumonia, you see, when we put people on ECMO and they've gone home, there is a thing called you allow the natural history to play out in front of your eyes, because these people would not have survived on the ventilator. So when you're oxygenating them outside the body, you are watching day by day that how long it actually takes for the lungs to recover. And believe you me, sometimes we see in young people who've been otherwise fit and well, it takes about 20, 25 days, a month and a half by the time, but you've got to sustain the patient for that long from secondary complications, from secondary infection. So this is a different kettle of fish. It is not following the age-old pneumonia story that we knew before.
Yes, thank you. We kind of really running out of time because we've already cut into the.
Marianne, you can take another 15 minutes.
I can?
Yeah, you can.
Great. Okay. So moving on to Dr. Swaroop Hegde and admission to hospital. When should I go to hospital if I display symptoms? What are the levels that we have to think about? What are the steps that we, what makes us decide that, okay, it's time for me to get to the hospital? Dr. Hegde.
See, I'm going to have to go on this a little step by step. First thing we want to document is that we don't want people rushing into the hospital just because they're COVID positive. We have seen this during both the waves that almost everyone wanted a bed in the hospital. Everyone claims to be a VIP. Everyone tends to sometimes exaggerate the complaints that they have for an admission. And we at COVID dedicated hospitals do not take patients who are not who do not have any oxygen requirement, because that way you probably are denying a bed to a patient who may require that bed. And probably it is these minimally symptomatic patients that may be a cause of lack of availability of beds. I mean, I'm going to have to go on record, because sometimes denying these patients a bed can itself be an absolute hassle. So my criteria, I mean, which we usually recommend for most patients, is that what you need to do at home is when you get your first complaint, I mean, if it's a bout of fever, a loss of appetite, a generalized flu-like complaint, you go and see your local consultant, take proper whatever home medication that the consultant can offer. Azithromycin and ivermectin does have a certain role to play when you take treatment at home in the first 5 days. And in a lot of cases, with a lot of people being asymptomatic, I would believe that up to 80% of the people who present in COVID are asymptomatic. So they don't definitely need a bed. Loss of smell. I've seen a lot of people message us at 2 in the night saying it's a medical emergency, that they suddenly lost their sense of smell. Now, I'm sorry, but sense of smell is not a medical emergency. And that can happen even in a normal cold as well. People tend to exaggerate the normal cold complaints just because they assume that they're having COVID, or the moment the RT-PCR report is seen by them, then all of a sudden they start exaggerating every complaint that they have. So what are the guidelines? Well, if you're running a fever for a prolonged period of time that is not really coming around with the medication that the consultant has given, we recommend you to keep monitoring your fever. One thing. Second is keep monitoring saturation levels. Now, there is something which we call as a 6-minute walking test. So for those cases which have been persistently having fever or have been symptomatic for more than 4 to 5 days, we ask you to take a short walk, if you're comfortable enough, take a short walk within the house and monitor your saturation for over the period of 6 minutes. If you see a drop in saturation, and we're talking about a saturation drop of at least about 90, 91, 92 on walking saturation, then you do recommend to speak to your consultant and get an HRCT done, not a chest X-ray, because that usually may not pick the initial pneumonias. So we recommend to get an HRCT done. And usually for the more significant pneumonias, now that is a very transient number. There is no specific number that we have. We here in Bombay, where we run OPDs, we even treat up to 14 COVID pneumonia scores at home if their walking saturations are maintained. This is usually seen in the younger lot, people who are relatively more stable. But those who are definitely of the older age, who have significant comorbidities, with diabetes being the most significant one, and those who have any sort of kidney-based issues, those having liver-based issues where giving favipiravir, which is one of the oral drugs that are available, cannot be given in these cases. You're better off if you can go in for an elective admission, since the usage of remdesivir, which has been highly controversial, from our experience, works only when you give it in the first early period of COVID. I mean, it does not work post the 11th, 12th day. So that is why you're getting the mixed bag result, because a lot of cases that also present to us are way too late. These are patients who just don't want to get admitted in the hospital. They come with some pre-notion that if they are coming to our hospital, they're going to die, or we are going to kill them. I mean, it's one between the two that they have. And when they come with such a negative attitude, that can always be a problem for the treating physicians as well. So what's the criteria? Yeah, if you're having a running in fever for many days, which is not getting responsive, that's one thing which you need to be concerned about. But also I need to inform this, that having fever is a sign of immunological response. So it also means that your immunity is trying to fight back. It is kicking in, because in most of the older gentlemen and ladies who have come to us, the plus 75 category, fever was never a criteria. These guys were usually asymptomatic. It was only a drop-in or a rapid drop of saturation post the cytokine storm that results in most of them having to be directly admitted to the ICU. Now, that's where the problem arises, because ICU beds are not easily available, especially those with BiPAPs and NIVs and high-flow cannulas. And then you can end up being so late that by which time, apart from just oxygenation and assisted ventilation, there is no modality of treatment that can be offered to you. So yeah, you don't want to come in too late. At the same time, you don't walk in too early because of anxiety. Let your local consultant decide. But I think the 6-minute walking saturation test is one of the easy ways to identify at home if you have a significant pneumonia, and following it up by an HRCT report and confirming it with a COVID PCR test, you can use that as a guideline to decide for admission. But also I want to add this, that a COVID PCR report and an RT-PCR, a rapid antigen, which we call as a RAT test, may not necessarily be very accurate. So we at COVID hospitals rely more on your C-reactive protein, your clinical complaints, and an HRCT which shows an atypical pneumonia, because we have had cases of COVID-19 which have initially come negative on the PCR report, and then subsequently at the time of discharge, they come positive. Okay. So yeah, so that's why you need to keep in mind that having a PCR negative may not necessarily mean you don't have COVID. It may just mean that the PCR machine is not really picking up the antigen in the initial period. Yes. So yeah, you keep a pulse ox at home handy, and when do a 6-minute walking test. And if you see a saturation drop, speak to your consultant, get an HRCT done, and move forward. And in the first 5 days of COVID, the one test that we really recommend for most people to do is a normal CBC, that's a complete blood count, and a C-reactive protein. The C-reactive protein is a highly non-specific test that just picks up an inflammation in your body, which may be secondary to COVID. With the current pandemic of COVID around, in case you're running a fever, and if you can rule out the typhoids and the dengue malarias, and you see a high CRP, then yeah, you can have a discussion with your doctor and move it forward. But I think you should let your consultant be the best judge with regards to admission. And any patient whose resting saturation is less than 92, yeah, you don't need to do the walk-in test. You'd better walk into the nearest COVID hospital.
Yes, thank you. Thank you so much for that. This comes to you, Dr. Sarkar. This is more psychological. Being in a hospital with no family around is so demotivating. What do you tell your patients to help them to stay positive? We heard a little bit from Dr. Rajan, but how do you handle it?
Man, I think it's very, very introspective question. It's very difficult, because if you look at it in this way, you can really get philosophical about the issue. Because the entire way we have been learning to treat patients and the kind of conditions over a good part of last century has been sort of negated by COVID, because we were completely born and brought up on the paradigm that sicker the patient, closer the doctor. So now it has been, now all this seclusion, separation, PPEs, etc., have really have imposed this distance between the patient and the doctor. So we have to relearn our medicine, we have to redesign our hospitals. Now, coming back to the patients currently at this point of time, in as much as possible, since most of my time or our time is spent in the sort of war front of the ECMO areas and all that. So what we try to do is, patients honestly feel, I'm sure, they're not feeling very happier being in a battlefield. It looks like Vietnam, inside the ITU, all these machines and all these ping pong sounds all around you. But even in those situations, for people who are kind of awake, we use all your iPads and tablets and everything, and let them communicate with, because there is no substitute for somebody communicating with their loved ones. No matter how much care or what length of time we spend with them, there cannot be any substitute for a gentleman or a lady meeting the husband, the son, or a daughter. So you cannot never substitute this experience. And once in a while, unless the patient is in dire straits, we do allow them to wear a PPE and everything. You see, not many doctors wear PPEs inside critical care right now, because most of this PPE business is actually a legacy of the Ebola era, because Ebola spread by contact. So even half of the vaccines we are using now are a legacy of the Ebola era. So it does not spread by contact. So most of us would either wear an N95. People who are touching a patient would wear a surgical gown or something. But for the relatives who are not used to the ways of critical care, we make them wear a PPE, come speak to somebody who's sort of awake. But the real problem that is still there in a couple of areas. One is grief counseling and updating the relatives, I think has been a problem, because when it's very rough sailing, when you have hospitals running at 110% capacity, doctors, nurses, everybody is so pressed for time that did we really spend the amount of time we needed to with a set of very anxious relatives? And the other problem is that in the closing hours, in the closing hours of a person's life, the sicker they are, the more distance they are from the family. And I think that period, I don't think we have come to a sensible, rational way of handling that period. I don't think, whether in the first time or in the second time. And the last point is that you see a family who's been devastated by losing somebody very near and dear. I think in most places, the way we dispose of the bodies, the way we dispose of the dead bodies, are really, that itself is a trauma in itself, because various municipal bodies have these things. They wrap it on black plastic and they really tie you around like you were Tutankhamun from the pyramids or something like that, almost unrecognizable. And that gives rise to mistaken identity in so many times we read in the press. I don't honestly think we have a lot of learning and a lot of polishing up to do on those fronts. I would not term that to be a very human experience as of now.
Thank you. Thank you, Doctor. And my last question before, it's almost time, and that's why I think I put this question forward to Dr. Rautre. I belong to a gardening WhatsApp group. And, there's this colorful poster came up where all gardeners were told that composting causes black fungus. Misinformation like this is doing the round. So I'd be grateful if you could speak about it and tell us what is the cause of black fungus? Dr. Rautre.
Okay. The first thing you need to understand is that black fungus is omnipresent.
Yeah.
It's not something that's come up today and in your bread molds it's there, in various other things it's there. The point is it was in a relatively innocuous state, and it didn't to be such a lethal organism the way it is currently now. The lethality of this black fungus, the jury is still out as to what are the exact factors. Steroid has been incriminated in a big way. Steroid not in a generic way, but a high dose indiscriminate use of steroids, lowering the local immunity has one of the factors. There are reports also that it is actually the whole pathophysiology of the COVID, even in the lung, is that it causes a blockage of the small capillaries and therefore it causes the lung damage. So one of the postulates is that even in the nasal mucosa, it damages the mucosa by blocking these capillaries and the mucormycosis comes and lodges in that damaged area. It could also come through the various apparatus that have been used on this individual in terms of face masks, in terms of nasal catheters, in all these the water that is put in the humidifier, in the airways, etc. So the mucormycosis is there. It has been there before. It is there today. It will be there tomorrow. Why it has specifically proven to be so lethal is a multifactorial reason. One is that the host himself or herself becomes more vulnerable either by high indiscriminate use of steroids or because of the nasal mucosa being damaged or the host being a diabetic, particularly uncontrolled diabetes. These all contribute to make that innocuous fungus into a lethal cocktail.
Thank you for that. And so this wonderful evening comes to a close. And from what you all have all spoken and what Sudha Murthy, the chairperson of Infosys Foundation, has said, the next most powerful step we need to take is to get that vaccination into as many arms as possible. And thank you so much for this evening. It has been such an enlightening experience for all of us here and all who have attended. And thank you, Doctor, for giving us so much of your time and energy, and experience and expertise. Thank you. Over to you, Matilda.
Thank you, Marianne. Once again, I just want to second what Marianne has said. Thank you, doctors. I know your time is precious, but you have enabled us to understand more of this coronavirus that is really causing a lot of physical and emotional stress in us. We have a few questions which I'd like to put across to you. One is, it's just a Dr. Deepak Rautray. As there are no vaccinations for children in India, we hear that there are some increasing cases among children. So how do we safeguard children?
The vaccination for children, the trials are on. The Covaxin has already initiated 8 to 18 trials for the vaccine. We expect in the next 1 month, we should have the data out and their efficacy established. In the interim period, the same postulates for children hold as for adults, namely that we see children use face masks, they use distancing when they are playing around, and they are educated about hygiene, personal hygiene, hand hygiene.
Okay. So even when they're running around in the compounds and all that, they must wear a mask.
Yes. In children's case, why yes is because social distancing in children is easier said than done. When I answered an earlier question, I said, I am going for a jog alone. I can dispense with a mask outside. But the child playing with a couple of friends would be in close proximity and they are not into exhaustive physical work. So they would be well advised to keep their mask on always.
Right. Dr. Varghese, is steam inhalation necessary for COVID-19? Like if you have a symptom, people say do it 3 times a day, 4 times a day. But then we hear other reports in the media that it is not good for the lungs. What is your take on this?
Steam inhalation has traditionally been given with the view to moisten the mucus in patients in their tracheobronchial tree so that it comes out more easily when they're coughing. You cough when there is phlegm in your chest and you want to bring it out. And if it is dry and viscous, it doesn't come out easily. So steam inhalation in such a patient, it helps to bring out the phlegm more easily.
Okay.
But as you heard in this disease, it is not the pneumonia of a conventional infective pneumonia. It is a vascular occlusion because of a clot within the capillaries and the veins, and it is not a phlegm which is formed. And therefore, in the early stages, when it is just beginning to get clotted, beginning to get occluded, and you have that cough coming up from that, it doesn't help then. If, however, about 8, 9, 10 days down the line, you get a secondary pneumonia in those damaged areas of the lung which had occluded capillaries, we have bacterial now secondary infection coming in, and then phlegm forms. Then getting that out is helpful with steam inhalation. But a lot of people take steam inhalation right in the beginning. You know why? The hypothesis was the warmth of the steam will kill the virus and therefore it will not get worse. Completely unfounded, completely unfounded. So don't take steam when you're having the first 2-3 days of early mild symptoms. No need it. When you have the cough beginning at the time of the capillary occlusion, the beginnings of the storm, you don't need it at that time. When there is a secondary infection, then you need it. There's another hypothesis going around that it's the steam which brings in humidity and that brings in black fungus also. Again, unfounded hypothesis. So a lot of things are floating around, but you need to know when you need the steam. Steam only helps you bring out a viscous phlegm from your airway tree and lets it come out. Beyond that, it doesn't do anything else.
And how many times can we do steam inhalation? Is it 3 times, 4 times a day?
You have been sleeping, you have phlegm accumulated in different parts of the lungs. Morning time when you take it out, and when you probably may do it in lunchtime, but I would say morning and evening is what I would suggest before you go off to sleep and after you wake up from sleep. Rest of the day, I think it could just be normal.
Okay. Dr. Hegde, what's herd immunity concept, and does it improve with vaccination?
Herd immunity concept is a general concept which basically implies that when a substantial number of people in society get an infection and they develop some sort of immunity towards it, they act as a barrier to protect the balanced minority of the public that has not yet been exposed to the disease. Now, herd immunity is more of a concept, and so far as COVID is concerned, we yet haven't seen the herd immunity kicking in. That's exactly why we have seen a much larger second wave than as compared to a first wave. But in theory, epidemiological theory, if the general population were to either get COVID once, twice, and or be vaccinated simultaneously, and we do achieve a combination of both, which crosses at least about 50 to 60 to 65% of the population, then these so-called people who are already immune will invariably act as a barrier to prevent either their family or others in the society from getting infected. Yeah, the concept of herd immunity will kick in here, but for that we need to at least substantially vaccinate more than 50% of the population, and currently we are a little far away from there. So I think for the herd immunity part to kick in, we're going to have to wait till probably towards October, November, if the vaccination is prioritized, because right now we seem to have seen on vaccination.
Okay. Dr. Sarkar, is it safe for expecting mothers to take the vaccine? If so, at which stage of the pregnancy? And would you have any recommendations as to which vaccine is best for pregnant mothers?
Ma'am, honestly speaking, I'm a little bit thin on my obstetrics. The question, but as far as a general point of principle is concerned, the jury is still out on this question, because there has been, I believe, by and large, I believe there has been 2 sets of reports. First problem was created by the fact that when the principal 3 or 4 vaccines were tried out in the phase 3 trials, none of the trials ever included the pregnant women. So because pregnant women were never a part of any trial, you could not stick your neck out and make a firm assertion. Second point was there were some kind of sub-studies because in women who probably have been pregnant in and around that time, and there was a group who said that they had a slightly higher chance of miscarriage, right? So there's been I think that was a work from Germany perhaps, which stated that. So having said that, my kind of medical common sense would tell me that you have a word with your obstetrician, depending upon your stage of pregnancy, because the other fear in pregnancy is whether it's what is called keratogenicity, which means whether the vaccine kind of causes some birth defects in the fetus. Now, so far it's not been known. None of such instances have ever been reported. But whether in real terms it is actually associated with slightly higher miscarriage rates or not, I think jury is still undecided on that question, and it is best to have a word with the obstetrician as to what they feel about this business.
I think the ICMR has permitted the vaccine in pregnant women, preferably in the second trimester.
Honestly speaking, I would not really want to kick up a controversy over here, but ICMR changes its mind like the weather. It is easier to predict the monsoon than to predict what ICMR is thinking. So I would not endanger the future prospects from the pregnant mother, because so far the ICMR is yet to be headed by an epidemiologist. So forever they've been putting the wrestlers in a swimming pool. So anyway, that's a different story for a different webinar.
Yes.
But I would not do that. ICMR is like a child with attention deficit disorder. So I leave them in peace, and I would let the obstetrician adjudicate on that.
Okay. Dr. Rajan, what advice would you have for people recovering from COVID? What were you prescribed as? What were you prescribed for your recovery? Are there any tests that you have to do after you have, after a certain number of days?
The recovery period has been punctuated with a relative lack of anything medical to do. Okay. You just take your rest, have a nutritious diet, and since you've had lung infection, this is the magic that you need. You need to be doing your respiratory exercises in the form of an incentive spirometry. And I can tell you that I moved from 1,500 to now 3,000 volume of inspiratory volume exchange. And that has really cleared my lungs. So vigorous chest physiotherapy and exercise, good nutritious diet, and sleep as much as possible, because that was what you lost in your 10 days. And now I find that I'm more active and more stronger, and I'm able to get out and do about half an hour of walking around my flat block. And I think that was all because of the amount of rest I had. At the end of 2 weeks of the treatment, I was asked to do a certain number of blood tests, including the C-reactive protein and the D-dimers, and they've all shown a downward trend. And the doctor, my physician, has told me, Rajan, stay far away from doctors and hospitals and laboratories. Just get well and come back to us as a doctor. That's what I'm doing now.
Okay. Now, when you say nutritious diet, does it include non-veg and veg,
Yes,
or only veg?
If you're a basic non-vegetarian and your body is used to getting protein from non-veg sources, please continue that. I'm not asking a vegetarian to become a non-vegetarian. Eat whatever was your regular nutritious diet. If you were non-vegetarian, please have it. I don't see any reason for you to stop having a non-vegetarian intakes of food that your body was used to prior to the disease.
Dr. Sarkar, can you throw some light on this recent fungal infection? we had first the black, then it's the yellow, and now it's the white. So how can we prevent ourselves from this?
I think, doctor has already spoken about this. So just to tell you, I don't think there's much to add, because the whole COVID story, you see, if I spill the beans to you as a doctor, has been a journey through relative ignorance. We are like in a dark, deep forest with a little pencil torch in hand. And now and then we shine the torch in a few trees. And we tend to tell ourselves that there goes the path. You see, fungal infections have been seen before. The term black fungus sounds very ghastly. The fungus is not black. So anything we don't like should not be called black. Funguses are, I think, more or less colorless. They are not the same villain we are pointing it out to be, because the first antibiotic ever synthesized by Alexander Fleming came from a fungus. Because of a fungus, we've got all these antibiotics in front of us today. Penicillin comes from a fungus, Penicillin gyrus, etc. What is odd? Now, what is odd? What is odd this time is we've had diabetics before. We've had thousands and thousands of patients on steroids before. We've had people on pneumonia before. But something is causing a kind of systemic deficiency of immunity, a systemic deficiency of our defense systems, whereby these fungal infections are rearing their head again. With the mucor group of funguses, they are a little bit similar to the virus in the sense they get into the blood vessels and cause necrosis. They damage the tissues, and any damaged necrosed tissue looks black. So because of which they get their name, the black fungus. The trouble is that when somebody is desperately sick, doctor has got n number of things in their mind. Thinking about a fungus so far wasn't very high in your list of priorities. So maybe we were getting a little bit late in suspecting this condition. Because if you suspect it, you've got to take a tissue scraping or a tissue, get it tested. Then more often than not, that bit of tissue has to be excised. It does have a medicine. It does have some antifungal medicines, which at some day and age used to be more widely available. And in this, and the second wave of the pandemic, like Gandhi's non-violent movement, India has entered the era of shortages. We've been short of beds, oxygen, antiviral, every medicine. Every pharma company, to get to the top of the POPs chart, has to declare a shortage. Otherwise, they don't feel important enough. So the pharmaceutical workshop of the world looks like a granary out of grains at this point of time. So even that medicine is not available now. I think we've only had a lot of sickness and a lot of dead bodies. There's been no dearth of that. So that is worrying us, because once again, you've got to give your shoe size, your grandfather's Aadhaar card or something like that to get one ampule of antivirus from the government. So we are almost like a dark-skinned Soviet Russia at this point of time. So that is worrying the doctors. So doctors will give you an early diagnosis, but where is the early medicine? Comes the next question. But there is a bit of the puzzle which is definitely missing. And that bit of the puzzle is when we have a little bit of relative calm and can look back at our experiences, we need to answer to ourselves that why on earth did we see so much of it this time round? I don't think, we've had a definite answer to it, because people have had tons of people on steroids. We've seen very severe diabetics. But is it the convergence of all these factors which has caused this problem today? Maybe there was a bit of suspicion about oxygen contamination, which I think industrial oxygen suppliers have told us that is not the case, because industrial oxygen is pretty pure and they ensure us it's pretty clean. There is some aspersions about cleanliness, about the water used in the humidifier, about the plastic tubings and the masks. Some people are going on and on about excess zinc. because people have consumed so much of precious metal in recent times. Some of us run the risk of getting magnetized, because we've consumed so much of metals in all these healthy diet. We may be attracted by a magnet shortly. So God alone knows. So, but it is jokes apart, it's a puzzle. So we have to suspect it early. We've got to pick it up. And if God is kind, we'll have the medicines in hand to treat. And that's the best we can do. But again, we are a little bit blindfolded as to why we are seeing so much of it this time.
Right. Thanks, Doctor. Dr. Rautre, is remdesivir a life-saving drug for COVID patients? There was a big, people were running helter-skelter to get this drug, which was not available. So when do you actually administer this drug to patients?
Let me begin with a submission. Our understanding of COVID is work in progress. What was the panacea yesterday is today lying in the dustbin. Most noteworthy of that was the hydrochloroquine, subsequently the convalescent plasma. They were all the panacea at one time, but have subsequently been discarded. Last week, the chief scientist of the WHO, Dr. Soumya Swaminathan, has categorically stated that remdesivir has no role in the management of COVID. Having said that, I do know for a fact that a lot of us would use remdesivir. I have colleagues of mine who are using remdesivir as a prophylaxis, which means as a prevention, they take a weekly dose of remdesivir. And there are others who would use it in the early stage to preempt the onset of the dreaded cytokine crisis. So that is one side of the story. The other side is the chief scientific advisor of WHO has said remdesivir has no role and has even castigated the Goa government for advocating remdesivir.
Okay. Dr. Hegde, there's a concern from a Mumbaikar. Says that how many more waves can Mumbai expect? And Mumbai is now opening up. So the Mumbai trains and the buses. So what precautions do you suggest that people traveling to work take in Mumbai?
See, the reason for so many waves, I mean, if I were to categorically answer the question, it would be the lack of following of any rules and regulations usually in India. I mean, there was a very simple rule that you had to wear a face mask. But I can assure you that, I mean, we run a COVID OPD, and I can tell you that about 30% of the patients walk in without a mask, in spite of multiple boards and rules and regulations. There are those who wear a mask, but they wear it quite inappropriately, usually with the nose being exposed and only the mouth being covered, which kind of does not really serves only a limited purpose over there. So if you can adhere to the rules and regulations, like the way it is followed in countries like Singapore and South Korea, which means that you basically wash your hands, maintain a 6 to 8 feet distance, and wear any sort of a mask, but wear it properly. That is the key factor here. That's one part of the aspect that you need to follow. And the second thing is that, see, COVID is obviously going to be highly contagious in cities, like those in India, simply because the population here in the cities is vast. We do not have proper sanitary measures here. And that in houses here in Mumbai, we have a huge number of people staying in a much smaller area. So, the aerosolization of the infection is far more easier in cities like Mumbai. So you are going to have multiple waves so long as the people fail to follow the regulations. But once, I guess, infection covers a certain number of people within the city, and vaccination also kicks in full drive, and we do achieve some sort of a temporary herd immunity, I think slowly these waves will get converted to ripples, and by the end of the year, I think we should be completely done with it. But till then, you're going to have to follow the rules and regulations of wearing a mask pretty effectively, and as soon as possible, try and get yourself and your entire family vaccinated through whatever media and channels that are available. Just one period of mention, which has I don't think you'll have picked up on here, is with regards to the vaccination. See, we have a vaccination center in our hospital itself, and there is something known as a vaccination failure. which was notified as less than 0.5% for almost all of the vaccines that are currently in the market. But we have realized from our experience that the vaccination failure cases are far more than what has been initially mentioned. So my one recommendation to those who have been recently vaccinated or who are planning to get vaccinated is, after you're vaccinated, please make sure that you effectively wear a mask, preferably even at home, and maintain the protocols of COVID-19 effectively, even when you have just been vaccinated, because we have seen sufficient cases where people who have been vaccinated have gone on to express COVID infection, they have come COVID positive, and they have also managed to transfer the infection to other members of the family. So yeah, we would like to recommend that if you're going to get yourself vaccinated, just effectively follow the protocol pretty strictly of maintaining safety measures during the period of vaccination. But the final way to go about this is to get as many people as possible vaccinated. The pediatric vaccine, which should be arriving in probably about 30 to 60 days. There are trials going on for it. But till then, yeah, you're going to have to effectively follow all the rules. And yeah, we have made a recommendation to the Chief Minister here of not starting public transport like the last time it was started, before we are effectively sure that we have kind of achieved either a herd immunity or that the number of cases are significantly low enough where it won't cause a sudden spurt of the number of cases we saw during the second wave. So yeah, you're going to have to follow the rules and regulations here, irrespective whether COVID is there or not, right up till the end of the year. Yeah, I think that's what you're going to have to follow.
All right. Thank you, Doctor. We have really run out of time. There are other questions, but I think these questions will be sent to you by Suvin Narayan, and you can answer them then. Just to recap this whole thing, don't believe in myths. Rely on a doctor for the best advice. Continue with all the protocols, even if you're vaccinated. Like continue wearing your mask and keeping safe distance, washing your hands. Vaccination is safe as can be. Don't underestimate COVID-19 because your condition could deteriorate quickly if you're not careful. And yes, COVID-19, as Dr. Rajan would also agree, does cause a significant impact in your lives. One has to stay strong and positive. And I remember reading that from all this conversation, it brought to mind, there was these abbreviations that were on every social media, which said, don't follow men, or don't touch men, mouth, eyes, and nose. And there was another one that said, follow only women. Wash your hands, obey social distancing, mask up, exercise and eat well, and no necessary crowding. Thank you, doctors. Once again, you've given us your very precious time. We have extended this webinar by another half an hour, and we thank you for spending it with us. We also thank our sponsors, TCI, Renew, Power, Access Energy Group, and the Karnataka Pharmaceutical and Drug Manufacturers Association. Thank you, everybody, for joining in, and I hope we have more insights into COVID-19, and we hope to meet again soon. Thank you very much. Thank you, Marianne, for
Thank you. Thank you very much.
Thank you. Thank you.
Enjoyable session. Thanks.
Thank you.
Thank you, doctors.
Yes. Wonderful section.